Hi, this is Dr. Mahadevan, and we're going to conclude with the initial management of trauma patients, part 4. And let's start with disability or the neurologic exam. When we're talking about disability in our focus assessment, we want to answer 2 questions. Specifically, is there an intracranial injury, and is there any evidence of a spinal cord injury? So as part of our assessment, we're going to assess neurologic function. And there are 3 things that we want to do every time during the disability exam. The first is to assess the patient's level of consciousness, and we can either use the AVPU approach or the Glasgow Coma scale score. We're going to check the patient's pupil reactivity to look for a blown pupil. And then finally, we're going to do a brief motor exam to see if there are lateralizing signs or any evidence of a motor level from a spinal cord injury. Again, when assessing the level of consciousness, we can start with, we can use one of 2 approaches. The basic approach is AVPU, which we've discussed before, and that stands for the patient is alert, or if they're unconscious or not responsive, that they respond to verbal stimuli, painful stimuli, or they're completely unresponsive. So AVPU. A more sophisticated way of assessing a patient's level of consciousness is the Glasgow Coma scale score, or GCS, a scale of 3 to 15, 3 being very severe head injury, 15 being normal. The Glasgow Coma scale score has 3 parts to it, and the way I like to remember it is eyes, voice, motion. Eyes has 4 letters, so you can get 4 points for your eye exam. Voice has 5 letters, so you can get a maximum score of 5. And then motion has 6 letters, so a maximum of 6. And again, how do we score this? If your eyes open spontaneously, you get a 4. If your eyes open to voice, a 3. To painful stimulus, a 2. And if your eyes don't open at all, you score a 1. If you're oriented, or if you're a child that's crying appropriately, you get a score of 5. If you're confused, meaning you don't know the date or the circumstances around the traumatic event, you get a 4. If you're speaking inappropriate words, or if you're a child and you're crying, you get a 3. If a patient is moaning or making incomprehensible sounds, you would get a 2. And if the patient makes no noise whatsoever, you get a score of 1. And then finally, in terms of the motor exam, if the patient obeys commands, they get a 6. If they localize to a painful stimulus, a 5. If they withdraw with a painful stimulus, a 4. If they have a flexion response with painful stimulus, they get a 3, or a decorticate posturing, that's a 3. If they have decerebrate posturing or extensor posturing, they get a 2, and then finally, if there's no motion whatsoever, a 1. This is the Glasgow Coma scale score. So if I provide a painful stimulus to the patient, and they reach up and try to remove that painful stimulus, this is localizing. And again, when we're talking about motion, this would get you a score of 5. On a 6-point scale, localizing to a painful stimulus. Let's take a look at this patient. Before they come into the emergency room, not wearing a helmet, skating, and falling and injuring themselves. And they come to the hospital, and they're brought to you for evaluation. And when we do our GCS evaluation on the eye exam, the patient opens eyes with a painful stimulus. The patient only says help and stop that, and the patient localizes to a painful stimulus. What is the patient's Glasgow Coma scale score? Well, here's how we would calculate it. Again, if you open your eyes to a painful stimulus only, you get a 2. This patient was saying help and stop that, so inappropriate words. We give that patient a 3, and then localizing to a painful stimulus is a 5, and when we add that all up, this patient's GCS is 10. which is a moderate head injury. Why is determining the GCS important? Certainly, we can assess it serially. So if you go from a 15 to an 8, that obviously is concerning. If your GCS improves from 11 to 14, that also is helpful. So we can use the GCS for serial assessment. We can also use it for communication with other specialists such as trauma surgeons or neurosurgeons to communicate our neurologic exam findings or our level of consciousness evaluation findings. And then finally, it can help with management decisions. As I mentioned earlier in the lecture, if your GCS is less than or equal to 8, generally we're going to intubate these patients for airway protection. The next part of the disability exam is to evaluate pupil reactivity, and specifically, we're looking for a blown pupil in a comatose patient. A blown or dilated pupil, a dilated unreactive pupil in a comatose patient suggests transtentorial intracranial herniation that can compress the parasympathetic or outer fibers of the third cranial nerve, leading to this dilated and unreactive pupil. So again, if we look at this patient, we can see that this person's left eye is dilated, and if we were to shine a light in it and see that it didn't constrict, we would know that it was unreactive. And the reason for that is on this left side, this patient has a large intracranial hemorrhage that is compressing their brain, and eventually that could lead to herniation, and transtentorial herniation again can compress the third cranial nerve and lead to this dilated unreactive pupil. This is another patient with a blown pupil. If we look very carefully, this is the left side and this is the right side. And if we look at that right pupil, we can see that it's dilated in comparison with the left side. And if we were to shine a light into it again, it wouldn't react. And the reason for that is if we look at this patient's head CT, and on the head CT, this is the right and this is the left, what we can see is this white stuff right here, which is intracranial hemorrhage, which is compressing the brain and pushing it leftward or leading to herniation. And again, that can cause a blown dilated pupil as seen right here. And that is, seeing that blown dilated pupil in a comatose patient suggests that there is a neurologic emergency, specifically an intracranial hemorrhage. The final part of the disability exam is to do a brief motor exam, and this is not specifically looking at specific muscle groups, but a gross assessment of movement in all extremities. I just want to know, are they moving that extremity or not? And you're looking for two things. One are lateralizing signs, like they're not moving their right or they're not moving their left, or a spinal cord injury level. If they're not moving their legs, but they are moving their arms, you would be worried about a spinal cord injury as a cause for that lack of movement. So looking for lateralizing signs and looking for spinal cord injury specifically. And then after doing the disability exam, we want to expose the patient, fully undress them, remove any wet or contaminated clothing. Remember, wet clothing can lead to hypothermia, so you want to get it off. And by exposing the patient, it's going to allow you the opportunity to do a complete or head-to-toe assessment of the patient. You want to make sure that you look under collars and splints, that you log roll the patient, examine their back and buttocks, and look for any penetrating injuries, which can be very subtle, such as gunshot wounds or stab wounds. One area where we can potentially make an error is failing to fully undress the patient and look for these subtle injuries. This can lead to missed injury, so it's very important as part of exposure to, again, remove the patient's clothing entirely and look at every part of their body to try to identify injuries. And here's a case in point of a gentleman who heard 3 gunshots, and when doctors evaluated the patient, they found 2 gunshots, but couldn't find a third and assumed that it had missed the patient. But as the patient began to crash and they did a thorough evaluation, what they did is they looked underneath this pannus And as you can see, they found a third gunshot wound. And so it's very important to look, again, under collars, under splints, everywhere in the groin and the axilla, and certainly under rolls of adipose tissue like this to make sure there are no missed injuries. Another potential error in the treatment and evaluation of trauma patients is allowing the patient to become hypothermic. And if we do that, if we allow them to lower their core body temperature, this can lead to increased mortality. So it's very important in terms of preventing hypothermia to, once you remove all the patient's clothing, cover them with blankets. When you're giving them oxygen, use warm humidified air. And if you're giving them IV fluids, make sure that they're warmed. All of these steps can potentially prevent hypothermia. And again, we know that the patient's chance of survival drops with every drop in their core temperature, every degree drop in their core temperature. So we want to keep them as warm as possible. In summary, when we talk about the ABCs of the primary survey or the evaluation of trauma patients, we're talking again about airway, breathing, and circulation, but don't forget about protecting the cervical spine, doing a disability exam, that is a level of consciousness, evaluating the pupil for reactivity, and then a very brief motor exam, and then expose the patient entirely and make sure that you prevent hypothermia. These are the ABCDEs of the primary survey. Remember the philosophy of the initial evaluation and treatment of trauma patients. It's to identify and treat life and limb-threatening conditions. And you do that before you move on to the next part of your evaluation. Unlike medical patients where you do a detailed history and exam, we defer that detailed history and patient exam until we've identified and treated the life threats. That is the philosophy behind the primary survey, or the ABCDEs of trauma evaluation. And what are these life-threatening injuries that we want to identify and treat? Clearly, loss of airway, no patient, respiratory failure, and then those 4 disease entities that can cause difficulties with breathing: tension pneumothorax, massive hemothorax, flail chest, and open pneumothorax. With regards to circulation, remember the #1 cause of shock in a trauma patient is exsanguination, so look for bleeding, and keep in mind pericardial or cardiac tamponade as a cause of shock in trauma patients. With regard to our disability exam, think about intracranial injury or spinal cord injury. And then finally, do not allow hypothermia, and do not forget to evaluate the patient in their entirety to avoid any missed injuries. That has been an overall evaluation of the initial management of trauma patients. Thank you very much for your attention.